So welcome everybody. My name is Sophia Ahmed. I'm the lead of the Alberta Spore Unit Capacity Development Program, and it's truly our honor in conjunction with the CanSolve CKD Spore Network to present today's webinar, Equity in Kidney Health. What does this mean and how do we get there? Next slide, please. So I'd like to take this moment to acknowledge this opportunity that the University of Alberta and the University of Calgary are located on the territories of the people of Treaty 6 and Treaty 7. And we respect the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. So welcome all. Next slide, please. So we have some specific objectives for this session. So one, we all know that there are inequities in kidney health in Canada and around the world. We'll focus today in Canada, but we don't know how to measure them. And so that's the goal of today. We'd like to identify and understand the barriers to why particular and historically excluded groups are not included in research, and then come up with some action items. And we really would appreciate the feedback from the audience on ways, not just to understand the ways on how we can move towards equity in health, kidney health research, but what are some concrete things that we can do and start doing today? Next slide, please. So just in terms of some media disclosure, the next few slides are really some housekeeping things. So the presenter portion of this workshop is going to be recorded. And so that's important for people to know, but the discussion portion is not going to be recorded because we do want people to feel that they have a safe space in which they can air their opinions, their suggestions, their feedback. There will be images and screen captures of today's talk that will be used for promotion period purposes. But if you don't want to be part of that, that's totally fine. But just keep your camera off and change your name if you would prefer not to be on that. Next slide, please. So housekeeping, we all have such Zoom fatigue. You're certainly welcome to keep your cameras on throughout the presentation, but please feel free to turn them off. We do ask that you keep your mics off throughout the entire presentation unless you're called upon to ask a question or answer a question. But we do want you to ask questions, so use the chat box throughout the presentation at any point to put them in. If it's a question that you do not feel comfortable asking personally, please feel free to send to me or to Glenda, who is our esteemed moderator today, and she can ask it on your behalf in an anonymous fashion. If you want to ask your question verbally, just put the raise hand, use the raise hand tool in the bottom right of your screen during the discussion part, and you'll be unmuted. Next slide, please. Just to emphasize, this is a safe space. As we said, we're not recording the discussion part of this this webinar. Please know that you can say what you feel as long as it's respectful, which I have no doubt that this audience will adhere to. We want to hear your honest opinions, what you have to say, without any fear of repercussions. Next slide, please. Rules for discussion, you can read this as well as I. Basically, please use common sense, respectful dialogue. We won't interrupt each other. And that's it. So next slide, please. There is a survey that you will have received upon registration for this webinar. We please ask that you fill it out, and you will get the exact same survey after this webinar. And we please ask you to fill it out. And the reason for that is that tells us, how was this useful to you? Did you get out of it what you wanted? What are things that we could improve upon? What did you like? Because this is the beginning of a long conversation, and we'd like to build on today's discussion. Next slide, please. So without further ado, because everyone is here not to hear me speak, but this incredible group of panelists, which is moderated by our esteemed moderator, Glenda Roberts. And all the panelists, including Glenda, will have the opportunity to tell you a little bit about themselves and their experiences with kidney health and disease. So Glenda is our non-Canadian who's on the panel today. She's the Director of External Relations and Patient Engagement at the University of Washington Center for Dialysis Innovation and Kidney Research Institute. So welcome, Glenda. Thank you. Next slide, please. We also are truly honored to have people with lived experience on our panel today. So Charles Cook, who is a patient volunteer at Grand River Hospital Transplant Ambassador Program in Ontario, and Kelly Loverock, who is a patient partner in the CanSolve CKD network. Next slide, please. We also have nephrology researchers, nephrologists and researchers from across the country. Dr. Sandy Demansky is a nephrologist at the University of Calgary. Dr. Roland Park is at Women's College Hospital at the University of Toronto. And Dr. Jag Gill is a transplant nephrologist at UBC. So without further ado, I will pass the mic over to Glenda. Thank you.
Thank you very much, Sophia. And thank you to everyone who is attending today. I am very excited to have this conversation. But to start off, I would like to give my fellow panelists an opportunity to take 5 minutes to introduce themselves and to tell us what equity means to them, as well as give us a little bit of background about themselves. So why don't we start with Sandra?
Good morning. Thank you so much, Glenda. I'm very delighted to be here with such a great group of people today. So as was mentioned, my name is Sandy Demansky. I'm a kidney doctor and nephrologist, as well as a scientist at the University of Calgary. And my area of interest in the world of kidney health and science is the implications for one's sex, which is their biological features, being male, female, or intersex, as well as one's gender, which is, as many people here will know, a social construct of who a person is, and how that impacts kidney health. So that's where I come from today. In answer to your question, Glenda, what does equity mean to me? In the world of sex and gender, and as it relates to medicine, equity means to me equitable access, so fair access to care and, equitable access and care to all individuals, regardless of their sex and regardless of their gender. And when I think about gender, I think about a number of things. So this may include people's gender expression, which would be how feminine or masculine they are, their identity, who they are as, do they identify as a man, a woman, or non-binary, their gender roles. So what roles they take on in their day-to-day life, their relations, how they interact with other people, as well as a look at institutionalized gender, which is the power dynamics as it relates to gender. So when we look at one's gender, we look at all of that in addition to sex. And in terms of equity, my hope is that all individuals, regardless of how gender and sex fits into their life, will have equal access to care. The problem with gender or with equity in kidney health in Canada is that we don't really know whether there's any sex or gender equity in kidney health right now. And I think I'm really delighted to be a part of this because this is an important part of equity. We're not doing a great job of collecting or reporting this sort of data, both in our clinical care as well as in our clinical research. But having said that, with what little we know, we do suspect that very significant gender inequities exist. We know that when we look at the binary of men and women in gender, there are differences in terms of kidney outcomes. And honestly, we don't know anything outside of that binary. So I'm really delighted to be here, Glenda, with the rest of the panel, to have a discussion and to see how we can move forward with, first of all, evaluating equity in Canada and looking at how we can improve this. So thank you very much for having me.
Excellent. Thank you very much, Sandy. Okay, so why don't we go, and by the way, we have agreed that we are going to use first names today because many of the people here are physicians, but we also have several people that are non-physicians, and I don't want you all to be confused and call me Dr. Roberts. So next, why don't we go to Roland?
Hi, thank you very much again, Glenda, and thank you everyone and Sophia for inviting me. My name is Roland Park. I'm a clinician scientist and a nephrologist, and I'm the Vice President for Research, Education, and Innovation at Women's College Hospital. I actually joined Women's because it had directly a focus on health equity and really trying to address how can we take a look at everything we do in healthcare through an equity lens in order to improve access to care, to improve the care that's actually provided, and hopefully ultimately impact outcomes. I came to this actually by working, I was first in the United States where I did studies among patients who were of African-American origin and studying differences. I was working in the city of Baltimore, looking at differences in outcomes. And ultimately we then conducted genetic studies to understand genetics and if it was genetics that were associated with differences in kidney outcomes related to those who came from West Africa. And so that's the work that I've been doing and leading. And now I continue to do that work within West Africa and East Africa also to try and understand differences again based on genetics. But I want people to know that I think it's really important when we talk about equity and we're talking about diverse people, that it's really important that we think through what does equity mean in each one of those things about access to healthcare, about your healthcare, about who gets disease, who doesn't get disease, and how we actually treat people and recognize that we're not using race to describe your genetic ancestry because it's a social construct, but recognizing all the different things that are informing that self-identification. And we need to think through how we address that in Canada, given that we have such a multicultural society, and the idea is to make sure that they all have access to care. And so I'm really interested in hearing everyone's discussion today and really looking forward to the discussion. Thank you.
Thank you very much, Roland. And next we'll go to Kelly.
Hi, thanks. So as mentioned, I'm a patient partner with CanSolve, and I'm fairly new to the organization. I've been there for less than a year as a patient partner. And I come to the role as a patient caregiver for my son. So my son is 9 years old. He was born with chronic kidney disease, and it was identified at birth. So we've been, in that healthcare system since his birth, and we're still, I guess, in the pediatric or childcare part of it, and because he's just 9, and his kidney he has one kidney. It is dysplastic, or he has dysplasia, so that one kidney is abnormal. It's smaller than normal, and it doesn't function at 100%. It functions around 50%. So it's been a journey since his birth. He's currently stable, but we are at the hospital a lot for monitoring. And yeah, so sorry, I'm a bit nervous. It's my first panel experience. And I'm hoping to gain from this just the perspectives and insights and experiences of others on this panel. I'm really interested in hearing those. And I think equity in my context means being a full patient partner in my son's care, having access to his information and records and feeling a part of his care, and that it's accessible, and that our perspectives on his care and his perspectives on his care are heard and matter. And I'm particularly interested in what his transition will look like from pediatric to adult care, which in the grand scheme of things is not that far off. I mean, he's halfway through to adult care, and I'm a bit nervous about what that might look like for him. And because right now we have a lot of resources in one place. So yeah, that's what I'm hoping to get from this. Thanks.
That was excellent. Kelly, you're doing a great job. Welcome to the webinar world. So next, why don't we go to Charles?
Hello, I'm Charles Cook. I'm a two-time transplant recipient. I received my heart in 2016. I received my kidney in 2017. And on this day, 7 years ago, January 14th, I actually punched my ticket on the transplant train. I just found out that I needed a heart transplant. I've been in the medical system in Canada ever since then. Besides volunteering for the Transplant Ambassador Program here in Kitchener at the Grand River Hospital, I also volunteer with the local chapter of the Kidney Foundation. And most recently, I've begun to volunteer as part of the Action Project. My part is with the ACB Organ Health YouTube channel. And this is the part where I do my little disclaimer. Although I am a proud member of the ACB community, I do not claim to speak for the entire ACB community. The experiences that I share will be my own, as well as my thoughts and my opinions. I was born and raised down in the great state of Georgia, moved to Canada in the summer of 2006, and have been here ever since. As far as equity, what equity means to me is the same as equality meant to me growing up, which is equal access to opportunity. And simply what that means is equal access to the best healthcare possible in the kidney field, as well as all medicine. And what I'm interested in today is sharing my experiences, hopefully so that someone out there can either say that they agree with what I've been through or I'm totally off the mark, and then they will get the opportunity to share their experiences as well. And I'm always willing to share my experiences, tell stories, and I love hearing other people's experiences and their perspectives as well. So thank you for letting me be a part of the panel. I'm looking forward to it. That's it.
Thank you very much, Charles. And finally, we have Jag.
Good morning, everyone. I have to apologize off the get-go. I've been having technical challenges for the last 20 minutes, so I apologize for that. It's a pleasure to be part of this. My name is Jag Gill. I'm a transplant nephrologist or a transplant physician in Vancouver, Canada. Medical director of our program at St. Paul's Hospital, and I'm also involved in some of the national data work that we do, and I'm president of the board of the Canadian Organ Replacement Register, which is our national transplant and kidney disease registry. And I also am on the board as vice president of the Canadian Society of Transplantation. My role in equity has been as a clinician and as a researcher, and it's been, to me, equity really means, as has been mentioned by many already, equal access to care in our context. And in my context, I think a lot about kidney transplantation, and not just whether people get a transplant, but how quickly they get a transplant, what the process is for them to achieve transplantation, and what the outcomes look like after transplant. So equity along all of those pieces that are really key to individuals that are coping with kidney disease, and as we move forward. So that's the lens that I look at it from. I'm involved in a few different projects that are looking at our clinical pathways in which we can try to improve the experience and improve access to care, and for Indigenous peoples, for those in the ACB community, as well as the South Asian community. So I really look forward to the panel discussion, and I'm thankful for being part of it.
Great. Thank you very much, Jag. And I'm Glenda Roberts. I am a kidney transplant recipient, and this past month, I celebrated my 11th year. So I'm very excited about that. I am also the director of external relations and patient engagement at the Kidney Research Institute and the Center for Dialysis Innovation. But the reason I'm involved in this initiative is because I am also the chief strategist and chief operating officer for the Justice, Equity, Diversity, and Inclusion Center for Transformative Research at the University of Washington. And I was talking with my CanSoft colleagues a couple of months ago about the grant that they were resubmitting. And we were talking about what the goals were. You know, why was I involved? And clearly, they had asked me to come because of my experience in terms of diversity, equity, and inclusion. And in the course of having the conversation, because I have a business background, I worked at General Electric, Microsoft, GE. I worked at a bunch of different Fortune 15 companies. And so whenever I look at a problem, I always say, what matters you measure. And so I said to them, so what's the goal here? What are we trying to accomplish? And they said, well, we need to look at kidney disease. And I said, well, what lens are you looking at it through? Do you consider race? I said, in the US, race is a big deal, but I understand in a lot of countries, it isn't such a big deal. And, they had this very convoluted conversation that said, we don't really look at data in that way, and we don't think about things in terms of race. And I'm looking at the screen thinking, well, they definitely look like they're a bunch of different races, but I didn't want to say that because that was insensitive. And so I have a friend she lives here in the United States now, and she's from Toronto. So I called her up and I said, so is there any health inequity as it relates to kidney disease in Canada? And she said, well, in Canada, we have a national healthcare system and everybody has equal access to the healthcare system. And I said, yeah, I understand everybody has equal access, but does everybody access it equally? And what impact does that have on their kidney disease? And she said, well, actually, I don't know. I said, well, look, let me ask you a simpler question. Do they have any racism and discrimination in Canada? And she said, oh, yeah, we have some of that. And so I bring that perspective to this discussion because I think it's important from my standpoint to understand which people have kidney disease, how they're impacted by that kidney disease, and what actions can we take to ensure that they have equitable access to the healthcare system in order to address their kidney issues. So with that, I'd like to start with Jag by asking him the first question, because in our pre-meeting, he did such a great job of explaining kidney disease in terms of health equity, discrimination, and systemic racism as it is reflected in the Canadian system. So Jag, just tell us about the landscape and what we're dealing with from your perspective.
Sure. I think, Glenda, you've done a really nice job of articulating some of the perceptions we have sometimes as Canadians, I think, and I think looking at it from your perspective is actually quite insightful for us. But you're absolutely right. Racism exists, bias exists. If you look at the Canadian context as a general, we have a history of colonialism. We've had a very strong history in terms of the way our Indigenous peoples have been treated very negatively for generations. And much of that still persists. And in addition, we have a large multi-ethnic immigrant population that have been here for generations, and there have been similar issues with racism in those contexts. So for sure, racism and bias exists in Canada like they do in most other places of the world. In terms of healthcare, and I'll talk about it in terms of the context of a patient's journey almost through the kidney piece. We do have a universal healthcare system for sure, but the way in which people have to access it is not that different than it is in other places. You need to have a family physician. You need to get referred for certain services. You need to be able to travel to those regions. You need to be able to access the right resources. You need to be able to have that conversation and understand the context of what's happening with the different team members. And maybe you don't speak the same language, or maybe you don't see things in the same cultural context. And so there's a number of ways along the pathway where there's opportunities for bias to creep in, for just difficulties in access depending on how far you live from a certain center, how easily you can access testing that you need to get to get a kidney transplant, for example. So I'll maybe give you one example of this. So in British Columbia, which is the province that I'm in, all transplant activity happens in the city of Vancouver, which is in the southernmost tip of the province. And we're servicing the entire province and people that are an 8 to 12 hour drive away, including people that are in the Yukon, which is the province north of us. And so, if someone lives down the street from my hospital and needs a kidney transplant, they have a very different path and very much easier access to come in and see us, get the testing done, and have that all done in a timely fashion because they're in a big city with lots of resources. If someone lives in a rural Indigenous community, for example, that's 12 hours away from our center and 3 hours away from the closest center where they can get all that testing done, you've got different access issues right there, right? That's just geography. And then when you add in the fact that some people will go into an emergency department and touch the healthcare system in so many different ways, bias and racism and access, all that gets muddled in there as well. So I think it's, although we have a universal safety net where no one will go without medical care, the interactions that people have to have and kind of help they need with navigating the process really is variable depending on someone's cultural context and their socioeconomic status. And so those issues really do play into access. And so we've seen in Canada that if you're Indigenous, if you're African, Caribbean, or Black, if you're South Asian, if you're East Asian, you have reduced rates of kidney transplantation relative to Caucasians. That's a fact. We've seen that it takes longer in terms of access to transplant. Importantly, the outcomes are very similar, but the access to get to that point of getting that care is different. And we've described that for years and frankly struggled with how to move forward to fix it. But there's certainly some movement, I think in the last few years on that issue. But that's kind of the general landscape in terms of, what the general picture is like, and also what we know in terms of the data that has shown us that access is in fact lower, at least in the context of access to transplant in different groups.
You raised an interesting point when you talked about transplant and the fact that the rate of transplantation was lower if you were Black as opposed to some other group. To what extent do you think that is influenced by the EGFR algorithm?
It's a great question. I don't have a good answer to that just because no one specifically looked at that issue, right? But I think it's hard to know to what extent that contributes to the difference. I mean, I can tell you one thing. When you look at the differences in terms of access to transplant, when someone gets a transplant, as you know, they can get a deceased donor transplant by getting onto a wait list. Or if you have a potential living donor, you can get a living donor transplant, right? Where you're not going on a wait list. It's all dependent on just when the donor wants to donate and when you're ready to get that kidney. We always like that better, right? The outcomes are better with a living donor transplant. So that's what everyone, pushes for. But when we look at all those groups I was mentioning in terms of who has reduced access, the biggest difference is in access to living donor transplant, right? And with living donor transplant, really, there's a lot of steps that have to happen in terms of early identification, making sure that people have enough time to find potential donors, because it's not an overnight thing, right? It takes a lot of time to find donors, for donors to work up, get into that point to where transplant's doable. And so all that stuff does require some lead up. So to some extent, do the GFR formulas mess with that timeline? Because that's what we use, right? To say that someone's at this stage of kidney disease or that stage. I'm not sure, but it's possible that may contribute to at least that piece of it.
Interesting, very interesting. We recently did a study at the Kidney Research Institute on the American population as it relates to EGFR. And to be transparent, I recently served on the task force to reassess the use of race in diagnosing kidney disease that was sponsored by the National Kidney Foundation and the American Society of Nephrology. So I'm all up in EGFR right now. But one of the things that we looked at was a number of different data sources. And the study from the University of Washington showed that the higher EGFR, and I'll give one of the doctors an opportunity to explain that for the patients who are here, but it's the estimated glomerular filtration rate. Kidneys are filtered, and so it's how well are they filtering. And from a And while your EGFR, as a point of definition, can be higher than 100, we say 100 just because it makes it sound like a percentage and it's easier to understand. So it's how well do your kidneys filter. And one of the things we found was that for African Americans, on average, it took 2 years longer to get to that magic EGFR number so that you could qualify to get on the transplant list. And that means you're 2 years older, you're 2 years sicker, it's more difficult to get through the process. So that would be one of the interesting data I would like to see come out of the Canadian system to better understand what's going on there. And in the context of data, Jag, I'll ask you one other question before I move to the other panelists. What kind of data do you currently have, and what have you seen in terms of research as it relates to how you track and quantify people's experience with kidney disease thus far, recognizing that you don't use race? How is it evaluated?
That's a great question, Glenda, and I think really kind of topical as you've highlighted, right? So race does get captured, right, in terms of most of our registries, in terms of many of our data systems. But I'll be honest that a lot of it is a bit antiquated, right? So how it gets captured, how race gets categorized is not really consistent. And so we do have data, for example, so in our province, we, every patient, or the vast majority of patients, have, race captured, but it's categorical as opposed to kind of truly it's self-reported, but categorical. And a lot of the times what happens with capture of race in general in databases is that it's not, the process around how it gets asked and how it gets captured is not really clear. So what ends up happening is a lot of times race is not necessarily being what someone is saying, I am of this race. It's often being assigned by the person who's filling in the form. And that's one of the challenges that we've been struggling with. Having said that, we do have kind of race captured in most of our registries so that you can track things like transplant rates over time and those kinds of issues. But really, we don't have granular data beyond transplant rates, kidney disease rates, those kinds of things. Do we know about the patient experience through the data we have? Not so much. There isn't a kind of a concerted effort nationally to say what are patient reported outcome measures and those kinds of things where they say level of satisfaction and how those things are going. They're being done in certain provinces, and that's something that is really improving. There are also some opportunities to improve our data collection. We're actually in a place in Canada now where we're starting to develop a national registry that is a bit more robust, and that's in the development phase. The federal government has invested a ton of money into that recently to actually develop a more with proper metrics. And there's a big push to say that race capture and these measures you're mentioning need to be part of that, right? And I think that's kind of where we are in terms of the race. In terms of general research that's happening in there have been multiple people now that are doing work, and we've been part of this in terms of doing more in-depth qualitative type work with patients from different groups to try to understand where the issues are and what the experience looks like. And that's yielded some pretty interesting results that we can get to as we just have discussions here today. But that's kind of the current landscape of big data, big registries that has a pretty kind of crude capture of race. And then you've got more granular studies happening here and there that are getting some more detailed and nuanced understanding of the situation.
That's a good way to transition to Roland. Roland told us earlier that she worked in the US and worked with African-American patients. And I'd be interested, Roland, in hearing about what your experience was like when you returned to Canada and you started to do your research.
Thanks so much. So it was interesting because when you study it in the States, it was required both from an NIH perspective for data reporting of who you've recruited in your studies. There were very specific categories you had to fill out. And it was I don't think the best classification of persons, but it was a standard classification that was used across the NIH. And so every time you did your annual report or your final report, you had to show your distribution of participants and really try to justify why you hadn't recruited in certain areas. So that was one thing that was different when I crossed over. The other thing was the discussion of race in the United States. Canadians talk about not having racism, and I grew up in Canada, and I immigrated as an immigrant in the 1970s. And I think the idea was that because we think about this universality of care, we think about everybody has access to everything, and we feel like we're very good at protecting those who are most vulnerable. There's this idea that perhaps we're taking care of everyone. And I think it's just become more and more apparent that in fact, there clearly are implicit biases that people didn't recognize. And perhaps not intentional, but they were definitely being impacted in clinical care. And I think that when I first moved, which was not that long ago, which was in 2008, I had shown a lot of the data as I was coming up here about looking at different ethnicities and wanting to understand from a genetic perspective, especially within Toronto, among a large South Asian community, an East Asian community, and a large Filipino community that were on dialysis, that perhaps we could take a look and see biologically if there's something that we could learn that would then have an impact for all people in the world with kidney disease. And I was told specifically that we don't collect data on race. And that in fact, race was something that was not to be asked. And I actually received significant pushback from the ethics boards about including race, and that it shouldn't be included. And in fact, when I insisted on it and I explained why, and I went through the rationale, I was able to show that in fact, by making it self-identification and being able to go back, and I go back 4 generations. So I ask what the 4 grandparents are. And then I use a standardized Statistics Canada classification where you can check all that apply, so that we try to get the multicultural fabric of how people self-identify. And I think that was something they hadn't seen before, because again, most people had gone back and defaulted. If you were collaborating with NIH, you just defaulted to the NIH groups. Mm-hmm. And so I didn't think the NIH groups really reflected what we needed, and I really wanted there to be self-identification. And so what I recognized was that as larger data sets were being used, I recognized that decisions were being made on somebody's ethnicity and their self-identification for the Ontario Renal Registry. It was based on what people thought they were, not what they actually were. And so I think that is just, fraught with problems. And it really is it's a significant issue. And I think that it's almost better not to have it than to have somebody assumed just based on skin color. And I think, especially when you're multicultural, I think, and we have lots of admixture. We think we've got about 30 to 40% admixture across the continent, across the country, which is pretty high and probably going to get higher over time. And so if we don't do self-identification, I think that really is a significant issue for us. Then we won't really be able to disaggregate data and understand the differences by these different self-identified ethnic groups. And so, so I think one of the things that I really tried to push people to do is that you're standardly collecting it in research. You are using categories that are appropriate for the Canadian context and not just assuming categories. You understand that people can come from multiple groups. And my daughter just filled out something for Oxford, an application, and in there, my husband's Irish and I'm South Asian, and there was multiple different categories, and she actually didn't fit into any one of those categories, even though they had multiple subgroups. So the idea is that you shouldn't try and presume that you know what people are. It's better to let them self-identify and choose multiple. And we should really be thinking about that in the Canadian context. So we're not trying to pigeonhole people either, which is actually what the UK classification system did, at least at the Oxford, when you did your submission. But it was very interesting. I thought that they actually tried to capture mixed children, but the mixed kids, they tried to then classify the individual, like who's mixed with who. Like it was crazy to me. Anyway, I was just an aside. But I think what's interesting also is that my children, find it deeply offensive as children who come from different backgrounds to not have the ability to reflect who they are completely and are being told to be pigeonholed into these different groups just because somebody else has done that for them. And so I think it's interesting. We've had some interesting discussions at home recently about this sort of self-categorization, and it's better to describe the whole person than the individual person. So I think from a research point of view, I think what's been good is that we've been able to challenge people a lot about being able to do things. And what we have tried to do is use other surrogate measures. And one of the things that we can do in Ontario is that we've been able to use naming programs. Again, just use the last name to classify, are you Asian, South Asian, or East Asian? But again, it's a very crude measure. And so I think going forward, I think at a provincial level, we need to really advocate for it to be collected once and collected systematically. And I think that as nephrologists, we should advocate for that. And I think that we should try to get other societies to really advocate for that also, because we're not going to be able to really do this well unless we can do self-identification at the time that people actually get their health card. And so when you get your health card, you are linked to getting all your other health care, and it collects information about you, where you live, how long you've been in Canada for, like it has all that information. And we can tell when people move from province to province. So I think we need to be able to say to people, this is the next step, is really having self-identified ethnicity when you get registered for your health card. So that's sort of what I think would be a great actionable thing that we could do, so that data systematically within the country, we will always have a standard way of collecting it, and we have a better way of collecting it. I think the other thing is, what I think has now changed is people are willing to say, let's collect data. And I think 10 years ago, people didn't want to know. And I think people now want to know. And so I think this is why we're sort of trying to catch up. And so I think it's going to take us a while, but I feel like we need to accelerate this a little bit faster, and we can't wait another decade without having data. So we really need to move so that anything that happens has to collect that information now, and has to do it prospectively. And we need to think about how to make sure that that can happen. I think, did I answer all your questions, Glenda?
Yes, you did, but you actually raised another question for me. When you talked about the fact that it would be nice to have a consistent way of self-identifying across Canada, do you have any consistent way currently in Canada that people can self-identify?
So we have Statistics Canada, which goes, I don't know if others know well enough, but it happens every few years, but it has a way that we're able to check as you identify multiple, you could identify multiple ethnicities, or you could say you don't know, or you could, identify one. And so I think the idea is that we should probably all use that same kind of classification, because it's broad enough to include all the different groups. But they roll up into larger categories. It has also much more detailed Indigenous self-identification sort of groups from different communities. So I think that's really important. So I think it's making sure that we're not restricted. We're actually being as inclusive as we can of the current communities within Canada. And so I think that's really important, that we're quite broad.
Okay. And one other question, because, I work on a study called Apollo, where we're looking at people of recent African ancestry. So is there a reason that we can't say use ancestry as opposed to self-identifying? What do you see as some of the challenges with doing that?
So I think when you take a look at genetic ancestry, you're actually taking a look at different substructure populations, the way we take a look at it. For example, did your families come from Northern Europe or Southern Europe? Did you come from West Africa? Did you come from East Africa? Did you come from Asia? And we're able to tell populations of where they come from based on certain ancestry informative markers. But it gives you large areas that you come from. But what I think happens that people forget about is specifically about APOL1 and the Apollo study, is that West Africa is very significantly different to East Africa and very different to Central and South Africa. So to say in that continent of 1 billion people, when you come from Africa and you've had recent African descent, I would say, well, what does that mean exactly? And so I would challenge people that I think that that's difficult now in current days because our immigration is changing, just like it's changing in Canada. That might have been okay when I was doing the project that discovered APOL1 in 2000 we started. 20 years ago, there wasn't as much admixture, there wasn't as much population coming out. So we were able to do the study to say the past 4 generations, there's been no admixture. And so when we looked among those people who self-identified as African-American, 80% of their genome was African. I don't think in current times, 20 years later, that that's actually still the right way to do it, because now you have lots more admixture. You've had people come from East Africa, you've had people come from the different areas in the Caribbean, you've had people come from Brazil, and all over the place that carry APOL1. So I think it's no longer using your self-identification to link with your potential genetic risk. I actually think I would actually separate that completely. There's lots of value in self-identification to understand, are there dietary changes, is there cultural practice differences, are there beliefs, or how you cluster as a group in what you believe in that may have an influence perhaps on your diet and then your kidney disease. But that's very different to then looking at your genetic ancestry, which would be totally different.
Mm-hmm. Thank you. That was very interesting, Roland. So that takes me to Charles. Charles, tell us how you self-identify, and do you see any medical problems with the Canadian system in the way that you do self-identify?
I am African American is how I identify myself. Black, more common word. But what Roland said kind of about her kids, from my previous marriage, we have 2 kids, a son and a daughter. So there's also Native American Cherokee from South Georgia in my background. So my kids are African American, Native American, and from their mother, Irish, German. And there's no, like right spot for them to check. Mm-hmm. So I guess the answer is yes, there's a problem there.
And as a kidney transplant recipient, do you see any issues with the medical system, especially as a Black or African American?
Absolutely. You pointed out the EGFR, and that's kind of a thorn in my side. Every time I go to do blood work, which I'll be going to do tomorrow, I'm going to get my results back. And on that little piece of paper, it's going to say for people of African American descent or from African descent, their results need to be multiplied by 1.15, which means in essence that my results are the same as somebody else's, non-Black or non-African descent. And by using that formula or algorithm, it's going to say that my kidney is healthier than someone else's. And as Jag pointed out, that extends the time that you need to get onto the waiting list for a transplant. I've had 1 kidney transplant, and as we all know, kidneys have a shelf life. So I'm looking at it as the next time that I need to have a kidney transplant, then I'm going to have to wait longer. I'm going to have to be sicker, as you pointed out, in order to get that opportunity. I'm going to go for the living donor transplant route because that has better outcomes. It's a faster way to go. But going into that, I know already from the data that has been collected through the Action Project that I am 50 to 70% less likely to receive a living donor transplant than a white person in Canada. And that is a major issue for me personally.
You mentioned the Action Project, and it's the second time that it's come up. Would you tell us briefly what that is?
From my short time with it and understanding of it, it's basically understanding the inequities that exist in the Canadian medical system for people of the ACB community here in Ontario, also the South Asian community, as Jag mentioned, in British Columbia. And we're trying to find out why things are that way. We know from the data that that is the way it is. Why is it? And then what can we do to fix it? And as I said, my part in it so far has been with the ACB Organ Health YouTube channel as a member of the advisory committee, helping to create content for our community to provide information. Just like I said, I think that's part of it, is just the information is not out there yet, that there is such a big disparity. And once people see that, and then they say that there is a problem, the first step solving a problem is admitting that you have one. To me, it's a personal issue, but I would like for society to say this isn't right for anybody, you know, to be that disadvantaged. So we need to do something about it.
So, and before I go, one other thing, I should know this. ACB means what?
African, Caribbean, and Black.
Ah, thank you. See, we don't have that down here, but I'm sure we do. We just don't self-identify that way. So Kelly, given that you are a care partner, I think you're the next logical person to move to. Tell us a little bit about the challenges that you have experienced in the healthcare system, if you have, with your son. You mentioned that he was born with one kidney. It was small. I think you said he was 9 years old or so. So he's been in the healthcare system for a while. So share your perspective in terms of some of the experiences that are related to equity that you feel like you've faced.
So when he was born, I think our first challenge was that he was, it was identified that he just had one kidney when he was still, like when I was still pregnant with him. And we briefly met a doctor after a level 2 ultrasound who said, who was kind of dismissive and said he just has one kidney. Lots of people just have one kidney. He can't smoke or play football, that kind of thing. And then I was still distraught, given, you know, this is my first child, my first pregnancy, and to learn that, you know, my baby wasn't 100% normal and healthy was still really upsetting. And then I think I took those few months to process that. And then when he was born, that's really all we expected. He would just have one kidney. But what happened was they did an ultrasound at birth, and then he got a bit of blood work. And for a few days, I ended up having like pretty traumatic birth, emergency C-section. And then this information was taken, but wasn't conveyed to us until the day we were meant to leave the hospital. Someone came and said, actually, he's not going anywhere. He needs to go to the NICU at the Children's Hospital, which is CHIO near us. So we learned at that point that something was really wrong. And one of the challenges was they sent a resident. We were in a teaching hospital, which is great. I support that. But this person repeatedly came to see us at different points, and rather than giving us like a fulsome sort of picture of what was happening, he kept saying, okay, it's a yellow flag, and then he'd go away and he'd come back, and then it was an orange flag, and then he'd come back as more blood work, I guess, came in, and different people looked at this blood work and his ultrasound, and then ultimately it was a red flag. And I remember like just not knowing what that meant, being completely overwhelmed, post-traumatic birth, and my husband and I didn't know what to make of it. And eventually I told this person, like, you have to get someone who can talk to me, because my mind is going to the worst places, and I don't know what a red flag is. I have no context for this whatsoever. So they sent the head of pediatrics, who sat down with us. And it was the first time in the whole process of pregnancy or having my son where someone said, okay, this is what we're seeing, and which is that his kidney was there. It didn't look normal. It looked bright. So it's dysplastic, I think is the term. And his blood work was not good. I think his creatinine was at 255, which is for a newborn really, really high, and which is why they transferred him to the NICU. And then they told us to go home, take our time and rest, so we went home, and the moment we got in the door, we got a phone call asking how soon we could get to the NICU. So that was a very panicked moment for us. I thought he was dying. I mean, I have anxiety, so I went to the worst place. And then when we got to the hospital, we were taken to a quiet room, lots of Kleenex, and we were told that it was very likely he would require dialysis because he was too small even to get a transplant at that point. He wasn't 22 pounds, which I recall them saying someone needs to be. So we had a lot of care within his first year. So there was the identified kidney disease, but then sort of to add to that, he also had an inguinal hernia. So they had to do an operation on that. And then he had a lot of issues with weight gain. And every time he would get sick, he would get severely dehydrated. So we just, in addition to his regular care, we were just ending up in the ER a lot, or at his pediatrician, and then sometimes being sent to the ER. And I felt, for me, that first year was so incredibly tough. Just, it was a very steep learning curve in terms of understanding what all these terms meant, whether it be like bright or dysplastic kidney. And then the one thing that I didn't always appreciate was like the predictions they would make at certain points, like when he was so young, telling us that he was going to end up needing growth hormones, and just really there was a lot of focus on his weight and his height and not meeting like those goals. So that was just an additional stress put on us in addition to like just his normal condition. I'm trying to think specifically, like that first year was the most challenging, and I feel like it was learning for us to navigate the system, for us to become his advocate, and then to try and get out of the doctors like more accessible language, like what does bright mean, what is dysplastic, like, and what's a realistic longer term scenario for him that's not worst case scenario, that's, you know, or sort of what are those like best case, worst case, neutral, rather than just scaring us. At times I felt that we were just given the worst case just to be prepared for that. I remember one time when we were still in the NICU and he'd actually had a good day, like he was getting blood work every single day, and the blood work, his creatinine had improved a bit, it had gone down, and it's 11 o'clock at night. I mean, we had been there for hours. It was all we were doing was going home, showering, going back to the NICU, and a resident, or one of the doctors, sorry, I believe he was a resident, he came in and he sat down with us and just rehashed his condition. You know, we'd had a good day, we were kind of feeling uplifted, and then he was like, you know, he has kidney disease and his outcomes aren't good. And I was like, and so we left really deflated, and I was like, what was, you know, the purpose of that, you know, just to, it wasn't anything new. It was, just felt at times like they wanted to bring us, they didn't want us to have too much hope. I guess. I know that sounds awful, but at times it was like just, and still when we go into his appointments, very often the doctor will start off with, so he'll tell us again, like he has chronic kidney disease and here's the situation. And we've been going for 9 years, like very familiar with his situation and why we're there. I'm sure it's, you know, probably for himself to kind of go over the file, but it's not always useful for us, I guess. And I feel like over the course of the 9 years, I've tried to demonstrate that, you know, we have the best of intentions for our son and we're doing everything from our end. And that I want to be, I think I'm pushing us to a place where I want to be recognized as more of a patient partner, if that makes sense.
Mm-hmm, mm-hmm. That makes perfect sense. You know, you made a number of points that I could relate to, because down here, we have lots of people who speak a variety of different languages. And frequently, when they're trying to engage with the healthcare system, there's difficulty because the providers don't necessarily speak the same language. And what you just shared with me is that there's a lot of different ways we can look at language and how it disadvantages people. While you guys spoke the same language, you really didn't speak the same medical language. And that's something that perhaps we need to be sensitive to. You also brought up the importance of navigating the system. And I know that for people, we have people here who are not registered as citizens, they don't have green cards, or they just aren't familiar with the healthcare system. And so frequently people feel like they don't get the best care because they don't know how to navigate the system. And it would have been helpful if you had had someone to help you navigate that system. Is that a reasonable assessment?
Yeah, I think for us, it was definitely a learning process. And I mean, the benefit of CHIO is that everything is actually really in one place. Like aside from his pediatrician, you know, we had access to ultrasound, the lab for blood work, all the nephrologists in one place, a dietitian that specifically was like in the nephrology unit. So that's, I think, why part of my nervousness about transitioning out of that care is like, do we need all those points of contact when he's an adult? And will they all be in the same place? And how do we find them? And, you know, yeah, that would be in that transition as well, I think, to have someone. But even at the beginning, because it was so overwhelming and because we were new parents, having someone to guide us or like maybe translate, you know, what these terms mean would have also been really fantastic.
Great, thank you. Thank you very much. And I want to make sure that we give Sandy an opportunity to share her perspective. One of the things we talked about earlier on was the importance of access to the healthcare system. And I think, Sandy, you brought an interesting perspective because you look at people in terms of all the ways in which we're different and in ways that we generally don't categorize ourselves. Say a little bit more, if you will, about Canadian access to healthcare, and in particular, the social determinants of health and how those things interrelate in terms of generating inequities in the system.
Thank you so much, Glenda. So I think that's a really important point when we talk about equity as a whole. So we know in Canada, we may not be able to describe it perfectly right now, but we know that there are a number of groups with significant health inequities. And it's very easy, especially as scientists, especially as doctors, where we like to put people in boxes to say, okay, this health inequity is because a patient is female. This health inequity is because a patient is Black. But I think when we step back and start looking at the bigger picture, there's a term called intersectionality, which basically brings it down to the fact that inequities are rarely due to one factor, right? So when I read in a research paper, for example, this group had poorer outcomes and also their income was lower. What my brain wants to jump to conclusions with is, okay, these people had lower incomes, therefore they have reduced outcomes. But the problem with that is there is not necessarily that direct connection between income and poorer outcomes. This might be a reflection of race. This might be a reflection of gender. This might be a reflection of sex. It might be a reflection of education. It might be a reflection of literacy, of language. And more commonly, it's a reflection of all of those things. So I think that's one of the difficulties when we talk about access to both care as well as when we discuss our outcomes, when we study populations as a whole, is it's very difficult to separate out what is a race-based inequity, what is a gender-based inequity, and all of the other groups that we know have inequities. So I think that's one of the biggest challenges in Canada, especially with what Jag and Roland were saying as well. Many of us don't fit nicely into one box. When we have the ability to self-identify, certainly there's a lot of boxes we can check. So when it comes to access, I think there's kind of, in my mind, 3 key features that are the biggest barriers, I guess, to both access to research and care. So, and certainly this applies in the kidney world in Canada. And I think one of the biggest barriers is a lack of diversity in terms of our healthcare and research teams, and more importantly, a lack of diversity in the leadership. So when we look at studies specific to sex, we know that participants are more likely to participate in a study if they see themselves represented. So if you have one female researcher on the team, you're much more likely to enroll female participants. And this applies to a number of different identities. So increasing our diversity and our diversity of leadership, I think is a really important thing we can do, because I think that's a really big barrier. And Canada's a very diverse nation, so I don't think this should be as big of a challenge as it has proven to be. The second piece is more about the practical barriers. So when I look at groups that seem to be marginalized from equitable healthcare, there's a number of practical barriers that we're just not addressing. So for example, some of this might be hours of care. You know, typically your family physician is open 8 to 5. Are you going to be able to take time off work? Are you going to be able to be transported at that time? For people with more feminine gender expressions, more feminine gender roles, they tend to do a lot more in terms of keeping the home and caring for children. But there's no considerations for childcare when it comes to access to health. You know, same thing applies for study hours. Care is also delivered outside of the home, which is probably the least accessible place for care to be delivered from an individual perspective. So I think there's a lot of practical barriers that can be addressed to improve access. And I think the third and one of the most important barriers to access when it comes to equity is mistrust. So many groups, racialized groups, gender diverse groups, other diverse groups, have a lot of mistrust in the healthcare system due to previous trauma, previous negative experiences. And it's very easy to ignore that, and it's as care providers, and it's very easy to approach our care without recognizing that, either because we're embarrassed of previous healthcare experiences, or we're uninformed or unaware of the mistrust that exists. So I think kind of prioritizing things like recognizing one's implicit bias, like practicing culturally safe care, and practicing trauma-informed care really helps us to include individuals that are presenting for help.
That's an interesting concept that I'm not familiar with. Say more about trauma-informed care.
Excellent, thank you. So trauma-informed care is a really important concept. And essentially what it is it's care that understands and respects the pervasive nature of previous trauma. So groups that are marginalized from healthcare also have higher rates of trauma, whether this be sexual trauma, violence, discrimination, a number of different things can contribute. And the trauma that's previously experienced really plays a role in who that individual is and how their future interactions are going to be in the system, as well as in the healthcare system specifically. So the goal of trauma-informed care is to ensure that we're not re-traumatizing people that are presenting for help. And re-traumatization may be in the form of having people relive their trauma or discuss their trauma when it's not relevant to their care, to treating the patient like they're part of a group as opposed to an individual. Talking to the person like they're the disease instead of themselves, not providing collaborative care. especially in sexual violence, disrobing can re-traumatize a person. So being aware of all of the methods of re-traumatization and trying to limit re-traumatization in the individual is really important, focusing on safety, collaboration, and empowerment of the individual.
Excellent, thank you. That was very helpful. So I'm going to become more disciplined now on time because we're starting to run out. And what I'd like to do at this point is to go around the panel and do a call to action, a discussion about what we see as the call to action coming out of this discussion. And Cynthia, if I have a chance to you, we'll get to your question at the end, but I want to make sure that we do have an opportunity to allow the panel to identify our calls to action. So we always start with JAG. So this time I'm going to start with the patients. I'm going to start with Kelly. Kelly, what is your, if we look at what we want to get out of this, what is the one thing that you would like to see us come away from this discussion with?
So from my perspective, as a patient caregiver, I think, I've been thinking about this, and to be fair, I haven't gone through this yet, so I don't know what it will look like, but a peer mentoring program or transition support to adult care. And also something that I hadn't brought up before, but access to information. So, I like to have access to my own health information and my son's, which we do. And I think that's really important as well.
And is that like through an electronic health system?
Mm-hmm. Yeah, it came into effect a couple of years ago. And for us, it was a big game changer when it came to appointments because we would get all his results beforehand. So then I would have time to go through them and think about the questions I wanted to ask, which was always really big for me. And then go into the appointment kind of knowing probably what we would talk about given the information like I was seeing in his files.
Great. I happen to like that. I do that all the time. Charles, we're going to let you go next.
All righty. I would like to have two. One is very simple. Just remove that if you're of African descent, then you have to have your EGFR multiplied by 1.15. It's kind of like, to me, going back to those old segregation era things where it's separate but equal, but it's not. There's no reason to have that on there. We know that doesn't work. So just get that off of all the results. That's an easy thing to do. Number one. And number two, Sophia kind of made my heart feel good at the beginning of this, saying that this is just the beginning. More conversations like this where we can actually talk and have patients' voices heard. It's very important because we're trying to do this for patients, people living with kidney disease. There's no cure for kidney disease. There's only two treatments. Either you get a transplant or you go on dialysis. And so more conversations like this, and what I hope comes out of it is, like I said at the beginning, that somebody sitting out there says either that guy is bringing up issues that are real to me and I'm glad that they're being spoken about, or that guy has no idea what's really going on in the real world and I need to tell him what's going on. And that is what I want, is for somebody else to do this next time and have different ideas and perspectives. And that's the only way we're going to learn and grow, because everybody has a story and every one of them is worth being heard. So thank you for listening to mine.
Thank you, Charles. Thank you very much. Sandy, we'll let you go next.
Perfect. This is going to be a little broad, but I think because we don't have a great idea of the landscape we're working in, I think an important call to action to come out of this conversation is to develop a national research strategy that's going to identify and describe the health equities we've discussed. And I guess more importantly, or as subtext to that, to make sure that we're including voices from diverse backgrounds to discuss these inequities, the barriers, as well as potential solutions. So I think having a more national approach is going to be of benefit. That would be my suggestion.
Excellent. Thank you very much. Roland, we'll let you go next.
Okay, I'm going to continue that theme, and I think also continue with the theme of blurred lines between clinical and research. And so I think that we need to recognize that addressing diversity is just like looking at a social determinant of health. And it should be embedded in everything that we do when we talk about clinical care, access to care, delivery of care, outcomes, or research. There should really be this idea that we're sort of measuring that as much as possible. So data. But one of the things that I really want to make sure is that when we're able to, as much as we can, patient, family, and community engagement should be partners in all of these changes. And what we should do is make sure that people address the diversity in the room for the questions that they're asking, and to make sure that they really have the right people in the room. And so the idea is that everyone's assessing how diverse are we, and are we the right people to actually answer this question.
Thank you, Sophia. I hope you were writing as rapidly as I am. Okay, and Jag, you get to have the final word.
No, thank you. I mean, I think I'll just reiterate a lot of the statements here. I mean, in terms of specifics, I think the call to action is for us to be very purposeful in this task. I think and purposeful around actually, doing things and moving beyond the discussion phases, because the discussions are critical, because that's what gets things going. But I think it's if each of us were to around the country say, okay, we're going to take one thing and we're going to really purposefully engage and we're going to purposefully move things along. I think that's the call to action. It's the little things that add up to the big initiatives. In terms of a very tangible, you'd said, what practices can we implement across the country? I think one piece that really is a potential win-win is improving and trying to get support for navigation support for our patients. And that's something that can be culturally specific, that can get into some nuance, and that can be a way to improve representation in some cases. And so we're in the process of kind of, as part of a study, implementing Indigenous patient liaisons across the province in BC to help navigate the transplant process. But that also immediately will improve representation of Indigenous peoples in the healthcare system as part of the teams. And so that's a kind of not a quick fix, but a start to try to improve a couple different pieces there. So those were my two thoughts.
Thank you. Thank you very much. And I'd like to thank all of the panel for your insights and perspectives. And so that we end on time, I would like to turn this back over to Sophia.
Great. So I have been, my arm is about to fall off. I've been taking so many notes. This is absolutely phenomenal. Thank you so much. And as Charles, you so aptly said, this is just the beginning or continuation of a conversation, and the beginning of great things. And Jag, I really like your point about, let's have purposeful change. As part of that, this audience, thank you so much for your comments and questions. Please fill out the survey that was sent to you, because we want to know what you heard, what you didn't hear, what you wanted to hear, because that will inform what we do next. So, and just to finish off, to thank all of our panelists for your time, your expertise, really appreciate it. Thank you so much, Glenda. It was amazing. And also just to finish off with, thank you, Diane Christensen and Kelly Buckreis and Linnea and Mila, all from CanSolve. Thank you for putting this together. So with that, wishing everybody a great Friday, and we'll be in touch. Talk to you soon. Bye-bye.